Good morning and welcome to my channel. www.painfreepartha.com is my website with slides and YouTube Pain Free Partha. Today we are going to talk something on supraclavicular brachial plexus block. Before that, I would like you to go to my YouTube channel, see brachial plexus anatomy website and the YouTube channel before going into this. So, supraclavicular brachial plexus is involving injection somewhere here. Now you can see the first rib here, and subclavian artery is inside the sheath of the brachial plexus, and anterior scalene muscle and middle scalene muscle have separated slightly. It is difficult to find out all these things, and they have become thinner. And there is a prevertebral fascia which has to be pierced, and there is a subclavian vein outside. This is where is the just on the first rib, just lateral and above the subclavian artery as a bunch of grapes. So this is what is the supraclavicular brachial plexus block. The supraclavicular brachial plexus block provides anesthesia to the upper extremity. It's an excellent choice for elbow, forearm, hand, everything. Sometimes they call it as spinal of the arm. Now things have slowly changed to costocavicular. The indications are trauma, dislocations, pain management, complex signal syndrome. All these things will come for almost all the breaks. Put the catheter and see the complex regional post-amputation pains. Usually it's an excellent choice for elbow, forearm, and also hand surgeries. The most important problem with this is the close proximity with this lung. That is why the risk of pneumothorax and pulmonary disease. Otherwise, everything is fine. Now the technique is, now we have found out the indications and we have found out the contraindications. The routine contraindications stay. For example, a severe coagulopathy patient, infection at the site, all these things will stay. But what is important is the pulmonary disease, and beware of the subclavian and lung injuries. A slight head up will decrease prominence of neck veins, and the head turns to the other side, and sometimes a pillow here will have a space in the neck. Now the technique, you can see the pillow here and the mid-clavicular point, head turns towards the other side, the arm by the side. No, not like this, because you don't have space here. Sometimes they see the anterior clavicle swing maneuver. They keep this like this. For example, you can have the clavicle swing like this, and you have a lot of space here. Is here the space you see, here the space you see. Because so this area is widened out with anterior clavicular swing maneuver. This is the brachial plexus which we want to go inside the clavicle and see these plexus. Yes, the subclavian artery is inside the sheath. This is the bunch of grapes appearance. This is a subclavian vein, the probe, and this is where you can see here. See, yes, the position is back flex 30 degrees, head up slightly, head turned away, arm is neutral, posterior, there is a room to needle here, lateral side away from the clavicle. Yes, we can also do like this. Rotate one another. Sometimes if you just rotate the lateral in lightly, you keep at the midpoint of the clavicle and you just go under the clavicle and slightly this lateral, maybe slightly above. What is the goal for us? The goal is to see the subclavian artery. This is what is the goal. Now you've seen the subclavian artery, the first strip, the white line below, and the pleura will be very close. And how do you differentiate first rib and pleura? Below that there will be shadows of the lung. Here the rib, no shadows. Subclavian artery, here it's a brachial plexus. This is the corner pocket, which is classically described. Now this is slowly going on because we know where is the trunk, and just give on the trunks. 8-ball corner pocket. That is why it is called corner pocket here. Axillary artery, brachial plexus. Yes, this is needle is coming like this, and here the middle cord, and here you drop this corner pocket and slowly get this lateral cord and all these things and give. This is a bunch of grapes, classical. Now you see the needle is coming from here. First strip subclavian artery, corner pocket injection. Lift up the brachial plexus and give here. Usually 5 to 6 ml here and 12 ml here. 20 ml is more than enough. Yes, we should see the homohyoid muscle is classical seen here, and sometimes you see the vein here. Beware, use the color Doppler. Travel road may be closed. Mild sedation. This I would like to give 2 milligrams of midazolam and fentanyl. And some patients may not require any aseptic technique. Glucose, chlorhexidine. I use surgical spirit in favor of evaporation. Sterile conduction gel, sterile probe cover is recommended, and this is definitely used for catheters. 20 ml is more than enough. Prefer 8 ml or 6 ml in the corner pocket and 12 ml inside the bunch of grapes. Two places, 6 ml each is also okay. Don't predetermine the volume. Yes, we know that we should give 20 ml. If everything is soaked within 18 ml, leave it. If you think that everything is not soaked in 20 ml, another 2 ml is okay. Just don't predetermine that I should give only 20 ml. All these things are possible. I use 0.5% bupivacaine alone in routine cases, or sometimes lignocaine adrenaline alone. I don't prefer mixtures because I have the idea that if you prefer mixtures, both will become dilute. So that is what is my idea about. So give 6 ml here and maybe 8 ml or 7 ml here, 7 ml here, something like that. Yes, we have found out that MELAO, minimal effective and local anesthetic volume for the lower trunk, is only 2.3 ml to produce 50% block. 99% 4.2 ml. The total upper limb may be blocked within 8.2 ml. So even though we are giving 20 ml. Truncal injection brachial plexus, a description of a novel study. Here they have found out 10 ml. On the trunks can be identified, targeted in the trunks. Now you can see the first strip, subclavian artery is a brachial plexus, and this root is going down into the, yes, you can see the transverse process, and the root is emerging again. Yes, you can see the transverse process bending up and forming the brachial plexus with a bunch of grapes of grapes. This is the two scalene muscles, interscalene groove. Yes, another root is coming. Slowly the subclavian artery is emerging. Subclavian artery, brachial plexus. Here I have already told the brachial plexus may look like this also, because your posterior direction or downward direction, that depends upon. Yes, you can see with this direction, sometimes you will see this. And sometimes you go down under the clavicle, you can see like this. The initial insertion of the should not be deeper than 1 centimeter because brachial plexus is very shallow. Bunch of grapes is around 1.5 centimeters only. Don't push in 3 centimeters, 4 centimeters. Dorsal scapular, transverse scapular, suprascapular arteries. These three arteries are in the needle path. Beware, color Doppler can be done to confirm the arteries. The complications most feared though rare is pneumothorax. Phrenic nerve block occurs in 30 to 50%. That is why we should remember interscalene block, phrenic nerve common, and supraclavicular approach to brachial plexus. Pneumothorax is dangerous. Yes, phrenic nerve block occurs in around 40%. Horner syndrome, transientosis can occur. Vascular puncture, subclavian artery can also cause hematomas. Nerve injuries are extremely rare, but they say it's 1.9%. Recurrent laryngeal nerve palsy, all these things are more common with interscalene approach. Pneumothorax is the most feared the rare complication, 0.04% or less than with ultrasound. Can be delayed in onset, can occur up to 24 hours after the block. So more problematic is many times you give supraclavicular brachial plexus block and you start giving GA with positive pressure ventilation. There only we have to be careful, because if it slightly prick the pleura and leave it alone, not much of problems will come. But if you keep a pleura in a patient with minimal wheezing, and also you give positive pressure ventilation after that, beware, monitor for 24 hours. Don't discharge even if it's an ambulatory case. Operator experience, needle visualizations, patient anatomy, tall, thin, asthenic build, COPD. Right side, the lung is little up. All these things put pneumo high. If you are experienced, you can see the needle completely coming down. And if the patient is not an asthenic build of COPD and left-sided, yes, the pneumo is at a lower risk. We already told corner pocket and brachial plexus. But I am telling you, the subclavian artery is there. The dorsal scapular arises from the subclavian. The transverse cervical arises from the trunk. Suprascapular artery. So SSA, DSA, TCA, subclavian. The danger of vascular puncture in supraclavicular brachial plexus block. Yes, I told the phrenic nerve is uncommon because in interscalene we keep it here, here, and in brachial plexus supraclavicular we keep it here. That's the difference. The phrenic nerve goes away. Costoclavicular versus brachial plexus, yes. Supraclavicular, costoclavicular. If you compare, costoclavicular is less chance of hemidiaphragmatic paralysis. On-off syndrome up to 4 to 37% at 24 hours, no treatment needed. Yes, we can have hoarseness with on-off syndrome after supraclavicular block. Yes, the close proximity of the sympathetic chain, more with interscalene. Yes, I have told the vascular puncture is very common because of these so many arteries. And thanks to Naizora lecture. Nerve injury or intraneural is an adjunct to ultrasound nerve stimulation. 0.4 MA intraneedle neural position may be likely. The needle should be withdrawn and directed. Neural pressure monitoring and less than 15 psi. So that is what is the importance of peripheral nerve stimulation. I will come back with another video. Corner pocket and complications. Already I have told the risk of pneumothorax. Yes, the most important problem of this supraclavicular brachial plexus is the sparing of the ulnar nerve. That is what they usually tell. But it is not ulnar nerve, and preferably the word inferior trunk sparing is better, because sometimes the whole trunk, all the branches get spared. We are bothered about ulnar nerve. The other thing, preferably the inferior trunk, lower trunk sparing is the better word. Lower trunk sparing is a better word. Why single point entry? We can give multiple injections, may increase the speed of onset and success. Required reduction of volume, but may carry. If you prick at 4 places, the fast onset, good action, but chance of nerve injury. This is the problem, multiple injections. Phrenic nerve block following supraclavicular block and successful reversal with doxapro. Sometimes what I used to give is, if you think that's a problem, after the surgery is over, you saline into that thing. So you dilute the thing, and sometimes the regional anesthesia will get reversed. This is what is called a reversal of regional anesthesia. Intertruncal approach. Yes, you can give this the upper trunk, which is divided into anterior posterior divisions. Give the drug here. Now it is beautifully divided. You can see the trunks with local anesthetics, and the drug is given here. Yes, lower trunk, subclavian artery, middle trunk, and anterior and posterior divisions of the upper trunk. Yes, we can see yes, we have to give the drug here, here. Beautifully, the divisions are seen. In diabetes mellitus, they say it blocks better. In very obese, the blocks are patchy. Beware of last because of the vascular proximity. Massive hemothorax. Yes, you have punctured the subclavian or you have punctured the suprascapular and you have also punctured the pleura. So to summarize, what is that? It is supraclavicular approach. Go to the midpoint of the clavicle and then see the subclavian artery. And very close to the subclavian artery in the first strip is the corner pocket. Give 6 ml or 8 ml. Come back to the bunch of grapes and then deposit 12 ml at least in 2 places. Avoid the nerve structures. Better to have 15 psi if you have a pressure monitoring. Vascular complications, beware. The most important complication is all about pneumothorax. 20 ml is enough. Thank you very much. Visit my site painfreepartha.com for slides, and YouTube is